All right, everybody, good evening. Welcome to tonight's Scleral Education Society webinar. Tonight we do have the great Barry Iden. He'll be presenting Misunderstandings in Keratoconus Detection and Interventions. It is a 1-hour COPE-approved webinar. So without further ado, I do want to introduce our presenter tonight, Dr. Barry Iden. He is the President and Medical Director of North Suburban Vision Consultants Limited, a multi-specialty group practice in the Chicago area. He is CEO and co-founder of the International Keratoconus Academy of Eye Care Professionals. Dr. Iden is also co-founder and president of iVisEye and Vision Research Institute. He is an assistant clinical professor at the University of Illinois at Chicago Medical Center and an adjunct faculty member at the Indiana, Illinois, Midwestern, Salis, SUNY, and UMSL Colleges of Optometry. Dr. Iden is past chair of the American Optometric Association's Contact Lens and Cornea section. He's also a fellow of the American Academy of Optometry and a fellow of the Scleral Lens Education Society. Dr. Iden frequently publishes in the professional literature and is a well-known lecturer, both nationally and internationally. And without further ado, I will turn it over to Dr. Iden.
Thanks, Drew, and good evening, everyone. It's really a pleasure to speak to what I would consider an extended family, and I miss being in live meetings with all of you together, and just hopefully over the next number of months that will change back to something resembling normality at some point in the near future. So again, welcome this evening, and as everybody knows, this is part one of a two-part presentation relating to keratoconus. Tonight, I'm going to speak to you about misunderstandings in keratoconus detection and interventions. And as you'll see at the end of the talk, the next speaker will be talking more about contact lens intervention for keratoconus. It's just a disclosure slide of some of the folks that I do some consulting, lecturing, or research with. And as Drew mentioned, at our practice in the Chicago area, I personally do spend most of my time dealing with patients with irregular corneas. The predominance of those patients have keratoconus, and it was a pleasure to establish an organization called the International Keratoconus Academy of Eye Care Professionals now about 6 years ago, with, as you can see on our executive board, a list of the who's who in keratoconus, both in the optometric and ophthalmological world. Our goal is to disseminate information, just like we're doing tonight, about the most contemporary concepts about the disease, its diagnosis and management, and you'll see some of the the emphasis of what we're looking to do to help patients have better outcomes in their management with this disease. In addition to our illustrious executive board, we have a phenomenal medical advisory board, again, of optometry, ophthalmology, and allied healthcare professionals. So it really is a pleasure, and I welcome any of you who are not members of our organization and have interest in joining our conversations about keratoconus to go to our website at keratoconusacademy.com. And if you go to the section subscribe, you will see that there is a complimentary code you can put in. So becoming a member costs you absolutely no money. So we welcome you, and hope those of you who are interested will join and join again in our conversations. We do many different educational efforts, some of them virtual like we're doing tonight, in the past many live, and some research projects we'll allude to a little bit later on tonight. So let's start out with what I would call misunderstanding number one, and that's just simply defining keratoconus. Well, a classic definition of keratoconus is of a progressive, chronic, and non-inflammatory ectasia of the cornea that results in corneal steepening, apical thinning, visual distortion, and potentially corneal scarring. And I think we would agree that this does sort of describe what keratoconus is once it affects our patients from a clinical basis and from a visual performance basis. However, we need to define it more specifically, and that is what I would call a clinical definition of keratoconus. And the one that I'm going to share with you in a few moments comes from a seminal paper that came out in Cornea in 2015 called the Global Consensus on Keratoconus and Ectatic Disease. And that definition is based upon corneal shape and thickness profile criteria. So we'll get to that in just a couple of moments. Let's just talk about some terminology so we can all agree. The term ectasia is often confused and misunderstood itself. A lot of people think that ectasia means thinning. It does not. It actually, if you look up the definition, it's defined as a dilation or distension of a tubular structure. In essence, it's the distortion and irregularity of a three-dimensional structure. Now, natural ectasia of the cornea is described by three predominant diseases, one being keratoconus, naturally occurring keratoconus, pellucid marginal degeneration, and keratoglobus. Here are a couple of terms that often, again, are controversial or misunderstood, and that being forme fruste or abortive keratoconus. And that forme fruste is often kind of like a difficult to define term, and if you look it up or you see references to it, you'll see a lot of confusion in that area. The way I look at it is that that is a subtype of keratoconus that has an attenuated or what we would term an abortive manifestation. In other words, it develops, it'll get to a certain degree of advancement, which is typically mild, and then doesn't advance at all and really kind of holds its own at an early phase as a non-progressive condition. Compare that to what I would call subclinical keratoconus. Now, subclinical keratoconus can be described, again, as a subtype of keratoconus that only has, well, today we'd use a definition of only having topographic abnormalities, that slit lamp findings would not be present, that vision would be normally correctable, and only through more advanced technology like corneal topography would we see evidence of keratoconus. Now, this term subclinical keratoconus truly is a moving definition, because as we develop more and more sensitive and advanced technologies, that will define what truly subclinical keratoconus is. And you'll see as we go on, those technologies are really something that we have to consider in making the earliest of diagnoses and hopefully early intervention. Iatrogenic keratoconus is basically a progressive form of ectasia after corneal refractive surgery, as we have seen in unfortunate cases, things like post-LASIK ectasia. So these are just some of the terminologies and kind of how I see defining those terminologies. We get back to that clinical definition I alluded to before. And this came from that global consensus on keratoconus and ectatic disease, the paper published in Cornea in April of 2015. And that was basically a publication based on a large group of cornea specialists throughout the world who came together in a Delphi sort of agreement format to come up with what they thought was a consensus. And surely this was a great first step, and I believe that certain things in this paper were wonderful, other things probably need to be developed further. But from that paper, they indicated that in order to use a true diagnosis, or to state that you have a true diagnosis of keratoconus, you have to have at least two of these three criteria. One being abnormal posterior corneal changes or posterior ectasia. The second being abnormal corneal thickness distribution. And then the third being a clinically non-inflammatory corneal thinning. Those terms are very important, especially the first two. You don't see any reference to the front of the cornea. The front of the cornea can in essence be absolutely normal and still have keratoconus. And you also don't see any reference to the thin point of the cornea in diagnosing keratoconus. They're talking about the change along the surface or from the center to the periphery, what is termed corneal thickness distribution. In fact, they state quite emphatically that central pachymetry is one of the least reliable indicators of keratoconus in order to make a diagnosis, and we'll see that in an example in just a moment. Take a look here, and we're talking about those two criteria. And on your left here is just an image of elevation of the posterior portion of a cornea. And you can see that basically the apex section of the cornea is indicated by the red area, and that means that there's an anterior displacement from the back surface towards the front. And you'll see in virtually every case of keratoconus that the elevation, the anterior elevation maximum at the apex of the cornea is always greater in the back of the cornea than it is in the front of the cornea. And that makes sense because if the back is pushed forward more than the front, what's going to happen at that point? Thinning at that area. And then up in your upper right, you can see what we call the way in which we measure corneal thickness distribution. So you can see those concentric rings. Imagine averaging the corneal thickness in each of those rings. And then along any meridian, one can actually determine the corneal thickness change or distribution. And as I mentioned from this paper, that corneal thinning at the center of the cornea is one of the least reliable indicators. Let's look at this example down at the bottom. If you look at curvature, anterior elevation, posterior elevation, and global thickness, and we'll see these in these tomographic maps as we move forward, one would agree that this does look surely like true keratoconus, and in fact it is. Now, if you look at the graph on the top left, you will see from the center of the cornea to the periphery the absolute thickness of this particular cornea, and you realize that it actually is within the normal distribution. It stays within 2 standard deviations of the mean of the studied normative population. So at its thinnest point, in this particular case, we're still over 500 microns, which, as we know, is statistically normal. However, down below is something called the percentage thickness increase, or PTI, of the cornea. It tells you the rate of change of thickness from the center of the cornea out to the periphery. And in keratoconus, what distinguishes it is this distribution and the fact that the cornea from its thin point or center out to the periphery thickens at a faster rate than normal. And we can see this is outside 2 standard deviations. You can see the center line, the black line is mean, and then above and below would be 2 standard deviations. And we can see this particular patient falls outside of those 2 standard deviations and has absolute thickness of the cornea from center to periphery that's statistically normal, but corneal thickness distribution is abnormal in that the cornea does thicken at a faster rate from the center to periphery. And that's truly the differentiating factor. Let's go on to misunderstanding number 2, and this is a big one out there, and that's the nature versus nurture controversy in keratoconus. It is fairly well agreed upon that keratoconus truly is a genetic and hereditary disease, but subject to what is termed epigenetics. What is epigenetics? It means the influence of the environment on a pre-established genetic pattern. So it says that the actual genotype is fixed, but the phenotype, meaning what is shown on a clinical basis for an individual patient, can be influenced by the environment. And we'll talk about the fact that there's overwhelming evidence for the genetic basis of keratoconus. We'll talk about some of those environmental influences, and we'll talk about the fact that now genetic testing in a clinical environment is becoming available to all of us. So this is just an example of a few studies and a few publications showing the evidence for a genetic basis for keratoconus. There are many. And in fact, if you look at the top one, the genetic aspects of keratoconus, it's a literature review that was published in 2018. And they did a literature review of 217 articles that were published between 2006 and 2017. From that particular paper, one of the statements is that 24 genes were identified as potential contributors to keratoconus. An earlier study published in 2011 also looked at genetics of keratoconus, and you can see below a number of statements from observations of genetic aspects for evidence, things like familial inheritance. And all of us who see lots of keratoconic patients realize that the majority of our patients don't know of other people in their family who have keratoconus. That surely doesn't mean they don't exist. They just aren't aware of them. But we all have these families where numerous patients within the family have keratoconus. I have one family that I'm thinking about right now that has 5 members with keratoconus. Strange as it is, the mom and the dad, the parents of this family, both have keratoconus, but they neither realized they had it when they got married. And then they had kids, and out of their 3 children, 2 of them have keratoconus. So, and then they have some cousins and so on and so forth. Also, some studies showing a higher rate of keratoconic agreement between monozygotic twins versus dizygotic twins, meaning fraternal twins, lower association of keratoconus in both of the twins. And of course, the association or comorbidity of keratoconus with a variety of other genetic abnormalities. And some of the studies have shown that keratoconus positive family history has been reported in about 25% of patients with keratoconus. But I can assure you and all of us who see relatives of these patients, to no surprise, if you ran topography and tomography on these patients, that a larger percentage of these patients will show some signs. They may be subclinical, they may not be affecting vision, they may not be progressive, but there's evidence that there is true keratoconus. And some of the studies, again, report inheritance patterns which are non-Mendelian very often, but sometimes have been reported as autosomal dominant with variable expression and incomplete penetrance, but it truly is not following normal Mendelian genetics. What about that influence of the environment? And we talked about the epigenetics, the fact that you must have a predisposition genetically, but the environment can influence how it expresses itself. The number one thing is eye rubbing. And although some people have claimed that eye rubbing causes keratoconus, I think most of us would agree that patients have a predisposition to keratoconus, but eye rubbing surely can exacerbate it. It can make it express itself in a more obvious way, and it could cause progression. The same thing can be stated with allergy and atopy, that we see a higher percentage of patients in the keratoconic population reporting atopy and allergy. So the question is this a genetic comorbidity, or is it being actually expressed more because they're rubbing their eyes more? Another one is hot climates and UV exposure. So many reports show a higher prevalence of keratoconus in nations with sunny and hot climates, also with greater UV exposure, like in the Middle East. But to me, that UV exposure almost is kind of a confounding variable, because we know UV exposure causes natural cross-linking of the cornea. Kind of an interesting thing to ponder. Out of this particular publication in 2014, The Genetics of Keratoconus, Where Do We Stand? This statement, I think, really encapsulates my view and I think kind of the most agreed upon view of the role of the environment and the role of genetics in keratoconus. So keratoconus, they state, is a multifactorial disease involving a complex interaction of both genetic and environmental factors that contribute to the manifestation of the disease. However, a majority of keratoconus cases occur as a result of the genetic predisposition that's triggered by the environmental factors. I think that's really well stated. We talked about genetic testing for keratoconus. This is really going to be an exciting new area, and all of us are going to have the ability to perform these tests in our office. I had the privilege of working and consulting with Avellino, who is now coming out with an approved test for genetic evaluation of patients with keratoconus. They were well on their way to coming to market before COVID, and unfortunately, they closed down during COVID to shift their efforts to COVID testing, and they should be commended for that tremendous effort. But now they're really ready to ramp up and get back out into our offices so that we can decide what patients really should be tested genetically. Of course, offspring of our patients, perhaps even siblings of our patients that may not know if they have keratoconus at this point or are at risk for developing keratoconus, and even use as a screening tool, if you would think, for refractive surgery, something to consider. One of our executive board members, Yaron Rabinowitz out of California, ophthalmologist, has been working on genetic testing for keratoconus for many years, and also has a lot of great information being put together. But Avellino is going to be something through their Avogen testing that we can do in our offices for our patients even today. So be on the lookout, because they'll be reaching out to all of us very, very soon. Let's go on to misunderstanding number 3. This is an important one. It relates to the prevalence, or how common is keratoconus in the population. You know, keratoconus has been kind of labeled as a rare disease, but we are realizing more and more that it's far more prevalent than we ever thought before. So I'll review with you quickly what's termed as classic prevalence numbers. We'll talk about some of the more updated and newer prevalence studies, and then I'm going to give you a little peek into a study that IKA has undertaken and will be coming out with our first publications this year on a pediatric prevalence study that we conducted actually here in Chicago. The classic prevalence, the 1 in 2,000 number that has been stated in many publications from many podium, interestingly enough, was based on a registration study from Minnesota that was conducted between 1935 and 1982. And Kennedy and his co-workers actually published these results back in 1986. And it was based on diagnosing keratoconus based on scissors reflex with retinoscopy or distortion of keratometric Myers. So as we know, we've come a long way, baby, and we're surely using technology that is much more sensitive. These particular findings obviously are important, but they do occur later on in the development of the disease, which results typically in a lower prevalence number. In the literature, prevalence numbers vary quite dramatically. And we could see numbers as high as 1 in 50 in a study that came out of Israel, and as low as less than 1 in 100,000 in a Russian study. Think about that sun exposure and heat environment difference between these two populations that probably has a significant impact. And these discrepancies, and there are many studies between these two, are or may be in part reflected by differences in the diagnostic criteria. That's critical. The older studies based on things like scissors reflex, the newer studies based on tomographic or topographic data, it's going to dramatically influence the prevalence numbers. The age group studied obviously will influence that. There seem to be genetic, ethnic variations within these populations, and as we alluded to, environmental differences and geographic differences. So we'll see here in the next slide that this past year in the journal Cornea, a systematic and meta-analysis review was published, and you can see a number of studies in this particular slide showing a dramatic variability in those prevalence numbers. And a lot of them have differences in diagnostic criteria, and others have differences in the population that was studied itself. And you can see in one of the studies here from Saudi Arabia, obviously a very hot climate, a lot of sun exposure. Look at that prevalence number. Almost 5% of the population in that study was found to have findings of keratoconus. And probably the one study that's been, referenced over the last couple of years most often comes out of the Netherlands. Well, that study looked at results, and by the way, topography was very commonly performed in these patients, but it came off of a study based on a 4.4 million patient database from a health insurance hospital database in the Netherlands. And in this particular study, they found a prevalence of keratoconus in the general population that was 1 in 375, which was really an eye-opening number. And in fact, even new cases or incidence of keratoconus was 1 in 7,500. The authors stated that both the annual incidence and prevalence of keratoconus in their study was 5 to 10-fold higher than in previously reported studies. So this really opened up a lot of our eyes to think about how common this condition is. Well, we at the International Keratoconus Academy decided that this was something important, especially in younger individuals. So what we undertook was a prevalence study of a school-aged population. And we've already completed our screening of subjects, and we are now doing our final data analysis and actually in the process of writing up our first paper. So this is a prospective observational single center study. The population was students who are in the school age population from grades kindergarten through 12 that were from the Chicago public school system. And in fact, these were students that were typically underprivileged. The vast predominance were African American and Hispanic. And these kids who failed vision screenings at their school were sent to a pediatric eye clinic that was run by the Illinois College of Optometry and the Illinois Eye Institute, where they got comprehensive eye exams. And what we did was we were able to put in a Pentacam to do corneal tomography as a screening tool routinely for as many of these kids as we could possibly run. So again, it was done through the use of the Pentacam as a screening technique. And what we did was we looked at some Pentacam software results, something called the Bell and Ambrosio third generation enhanced ectasia detection software. And this software basically looked at corneal elevation anomalies on the front and back of the cornea, as well as corneal thickness distribution anomalies. And without getting into great detail, it didn't look at all at curvature values on the front of the cornea or thin, or aspects that didn't relate to thickness elements and elevation elements of the cornea. And there are a variety of statistical numbers, but they were all put together to come up with a final risk factor, which is called the total D risk factor. And that will show you the standard deviation from the mean in their study population. And these patients that we ran were flagged if the total D value was greater than 1.6 standard deviations from the mean, and they would be flagged at this point. We also looked at another software from Pentacam that is called the Bell ABC and D Keratoconus staging criterion. These related to curvature values on the front and back of the cornea that are located within 3 millimeters of the thin point of the cornea, and also the thinnest point in the cornea. And so we got these A, B, and C values that are put on a scale from 0 to 4. And we flagged patients if either A, B, or C were greater than 1 in this particular software. So I'm giving you now a little hint. We're diving much, much deeper into the statistics, but out of the 2,311 patients we screened, that's a pretty big population. We were able to analyze about 92% of those particular screened individuals based on quality of their Pentacams. And we can see here the statistical numbers of abnormalities in A, B, and C criterion. In using the D criterion, over 1.6, over 15% were flagged. If we get a little bit more sensitive and less specific, then we're going to look at D values of greater than 2 standard deviations from the mean, came out to a little over 6% of the population. And if we look at 3 or greater standard deviations from the mean for the total D, we're looking at a little under 1%. Now, if we try to combine them and said, what number, what percentage of patients had abnormalities in both A, B, and C being greater than 1 of those factors, and the total D being greater than 1.6, it was 5.2% of the population. 1 in 20 individuals was flagged as potentially keratoconus in this population. Now, you still need to look at the actual maps themselves, and sometimes you'll get some kind of false positives in the numbers and even some false negatives, but basically you still want the clinical impression. And so we have readers who are going to ultimately be analyzing these particular maps and giving their impression, does it look like real keratoconus? And that will probably change some of these numbers. But once again, at least based on the software in Pentacam, 1 in 20 in our study of this pediatric population came out positive, which is absolutely amazing. Why is it important? Because in these young people, we have issues with keratoconus. If you develop keratoconus at a younger age, you generally have a poorer prognosis. Progression tends to be faster. There's an increased probability of ending up with if there's no intervention with penetrating keratoplasty. And even those that have had keratoplasty at a younger age of onset have a greater chance of ultimately rejection. So critical to us is to start diagnosing keratoconus as early as possible. The challenge is to get the proper sensitive technology into the hands of primary eye care providers, and that's a real challenge. And we want to have a goal of intervening through cross-linking before significant vision loss occurs. Take a look at this particular study from 2012 that looked at kids aged 9 to 19 with defined keratoconus. What this group found was they had a progression rate of close to 90%. That means that these young people, almost all of them, progress between that young age, under 20 years old, with keratoconus. So the authors concluded that they said that awaiting documentation of progression in that age group is not mandatory, and that they felt that cross-linking in those children and adolescents should be performed as soon as a diagnosis has been made. And as we'll see a little later on, current FDA approval for cross-linking here in the United States for keratoconic patients requires us to document progression, but maybe we need to look at it a little differently based on some of these quite overwhelming statistics. What's the impact of such a high prevalence in a pediatric population? One, we would indicate that the potential importance of keratoconus screening should be part of routine pediatric care. And I got to tell you, with our understanding at our practice, we have changed our pediatric screening. We do screen for keratoconus at ages 7 and above. We do run baseline penacams on these patients, as well as other screening techniques with more advanced technologies. And we would want to motivate ophthalmic instrument manufacturers to develop both affordable and sensitive technologies that would be able to be put into the hands of most primary eye care practices, because that's where the early detection and then early intervention would take place. The result would be a higher rate of early detection and hopefully intervention to prevent vision loss. So that's about the whole issue of prevalence, and I hope that really drives home some points to many of you listening tonight. The fourth misunderstanding, that would be early detection requires advanced technologies. We can't quite get away from that, because with standard diagnostic methods, looking at slit lamp, looking at keratometric Myers, refractive shifts, these patients that are diagnosed with that type of technology, well, vision to a certain degree has already been compromised. With the use of advanced technologies, we have the ability to detect keratoconus and potentially intervene to stop progression prior to significant negative impact on vision. We should, however, be very much more sensitive in our standard diagnostic techniques and look for those red flags of classic refractive shifts that should make that flag start flying pretty high, and that being significant asymmetries in refractive shifts, especially with higher degrees and asymmetric degrees of keratoconus, doing really careful slit lamps, looking for some of the changes, your careful retinoscopy, and so on and so forth. And now, thankfully, with the majority of ODs and MDs at least having placido topography in their hands, we're even able to be more sensitive, especially if we start thinking about utilizing some of these technologies as screening tools, especially in our pediatric population, and especially for the pediatric patients we see who may have a known family history. But the challenge that we have to industry is, again, to develop sensitive testing to put in the hands of those primary eye care practitioners. And I can tell you efforts are being made today, and I think we're going to see some really exciting new tools for us that will be affordable and applicable to primary eye care practices. So what are some of these advanced technologies today? Of course, most of us have placido topography. The problem, unfortunately, with placido topography, it cannot measure the back of the cornea, and it can't measure corneal thickness distribution. So by the time placido topography is abnormal, once again, it's a little bit more advanced. And so Surely we'd like to have technologies in our hands that can even detect it before placido topography is found to be abnormal. That's where things like shine fluke tomography come into play, because that technology has the ability to measure both the front of the cornea as well as the back of the cornea, as well as the global thickness of the cornea and its distribution, which meets the criterion of early diagnosis. We're also looking at other tools like anterior segment OCT, because we can measure with these instruments epithelial thickness distribution. And we know now that in keratoconus, we see abnormalities in epithelial thickness distribution on the front surface of the cornea. And that seems to be a fairly early sign of this disease manifesting itself even before vision is affected. And in fact, we had just a patient 2 days ago at the office who was frankly keratoconic in one eye, but in the other eye, even their shine fluke tomography was normal, and you would think it might have been a unilateral case. We'll talk about that in a few moments, but the epithelial thickness distribution was abnormal and classic in its pattern to keratoconus. What's really exciting to me is corneal biomechanics, because we also know that the biomechanical structure of the cornea in keratoconus is not normal. And in fact, we can see this video that you're seeing, and where you're seeing an effect of the cornea when an air puff is blown on it, and that's how some of these technologies work. And we have equal thickness corneas, both thin corneas, but we see the red one, that's a keratoconic thin cornea, and the blue one superimposed is a normally thin cornea. And you can see the difference in how the deformation of the cornea responds to the puff. And with new software that's being developed and awaiting FDA approval, some of these technologies will be able to analyze the corneal biomechanical properties and apply statistical analysis that we'll see in just a moment as well. Misunderstanding number 5, where does the distortion in vision come from in keratoconus? And it has been eye-opening, excuse the pun, for us after we introduced aberrometry in our practice a number of years ago, specifically integrated aberrometry, where you can differentiate the front of the cornea versus internal high order aberrations. And in keratoconus, what we've come to realize is that the back of the cornea actually has a definitive and measurable and impactful negative impact on visual function. Nowhere near as significant as the front of the cornea, but it does have that impact. And we can see here, if you look at the point spread functions, the one on the left is the total aberrometry, the center one is anterior cornea, and the one on the right is internal high order aberrations. Remember, internal high order aberrations in these systems really relate to the back of the cornea as well as the lens. So if you happen to have a patient who is keratoconic with a cataract developing, it can be a little confusing how much is from the back of the cornea and how much is from the lens, although new technologies will differentiate that, and we'll show you that in just a moment. And we can see some of the quantified numbers of root mean squared or RMS values and total high order aberrations broken down to the anterior cornea and internal are abnormal. Now this becomes very important when we're talking about contact lenses, because when we put a contact lens on the surface of a keratoconic eye, we will basically negate the front irregularity of the cornea, but we do very little for the back surface of the cornea. And we can see here at one of my cases where the top is total aberrometry without a contact lens on, showing the total point spread function, the anterior cornea, and the internal, all being elevated. Now below that, the same patient, we placed a scleral lens on the eye, and look what happened to the anterior corneal point spread function. It's reduced to almost nothing, but the total still was significantly elevated due to the posterior aspect of the cornea. And I'll show you a couple of other cases like that. Here's another one. If you take a look, left being total, center being anterior cornea, and the right being internal. In this case, the lens of the patient was clear, the crystalline lens, so we know that it predominantly comes from the posterior corneal surface. Now we put that scleral lens or any kind of rigid lens on the eye, and you can see the center is now reduced to almost nothing and statistically totally normal. I'm just blowing it up. Look how reduced that anterior corneal is, but notice how the internal is now expressing itself through the total point spread function. So these are the cases where you put a lens on and the patient reads significantly better, say it's better than it is with their glasses, but it's still not clear. And depending upon the kind of high order aberration, for example, if it's vertical coma, you might start refracting cylinder that's actually, you're really chasing high order aberrations there, and it's very, very difficult to address. Of course, new contact lens designs trying to address residual high order aberrations are really exciting, and some of the newer designs are looking a lot more promising for us. I'm going to show you another case that just was managed at our practice over the last month, and it's even more dramatic. This patient came in, referred in for contact lens management. We placed a scleral lens on their eye, wonderful fit, took care of all of those anterior corneal aberrations, but look how much internal high order aberration still comes through. This patient, I couldn't even refract better than over the contact lens, over refract any better than 20/30, and it was poor. And this is a patient that we're pursuing correcting high order aberrations through modification of the front surface of the scleral lens, and we're still in the process, so I don't have a scan to show you any of the outcomes yet. This is exciting new technology that's just been introduced very, very recently. And this is utilizing Scheimpflug tomography with integrated aberrometry. And for the first time, not only will we be able to differentiate anterior corneal versus internal, but it can break down internal to posterior cornea versus lenticular. So this is really exciting, and it's something that we're going to see a lot of research and a lot of clinical outcomes being presented off of this platform of new technology. Number 6, is there unilateral keratoconus? I believe personally the answer is no. The only reason why we think one eye is non-keratoconic while the other is keratoconic is we may not have the technology to actually find out. So we may have a patient who has classically manifest keratoconus in one eye, and we perform corneal topography, let's say using placido topography, and it's abnormal in the one eye, and the other eye is perfectly normal. Take a look at this particular case. Here in the upper left is corneal, anterior corneal surface curvature, and even elevation is statistically normal and clinically normal. But if you look at the back of the cornea, there's a posterior abnormality. And if you looked at global thickness, there's a corneal thickness distribution abnormality. So this patient might seem with placido topography to be normal in that eye and perhaps abnormal, clinically abnormal in the other. But if you did tomography, you'd realize that what appears to be clinically normal eye is truly keratoconic. Take that to the next level with epithelial thickness measurement with anterior segment OCT, and we can see the classic keratoconus pattern of apical thinning with surrounding thickening of the epithelium of the cornea. Take it to the next level with corneal biomechanics, and now we have the ability to come up with what is termed the CBI, or corneal biomechanical index, statistically analyzing the biomechanical properties. And a case can be where tomography looks absolutely normal, perhaps even anterior segment epithelial thickness or Scheimpflug tomography, but the corneal biomechanics are abnormal. And software has been developed and still awaiting FDA approval that would integrate both Scheimpflug tomography along with biomechanics into one single report. And we can see a case here. If you look in the upper left, this is corneal tomography using Scheimpflug. It's absolutely normal in this eye. The other eye of this patient is blatantly clinically abnormal. And we can see normal corneal curvature, normal anterior and posterior corneal elevation, and in fact, normal corneal thickness and corneal thickness distribution. So the Bell and Ambrosio analysis is perfectly normal. Yet, when we run corneal biomechanical analysis, it's absolutely abnormal. And that software that statistically combines both of these results comes out with a total analysis of abnormalities. So this is a case where, once again, you think it is unilateral keratoconus since the other eye is clinically keratoconic, but only through the use of biomechanics did we realize in this case that what appeared to be normal other eye is actually abnormal and keratoconic. Take it on to the next thought of misunderstanding. Is keratoconus limited to the cornea? What about scleral shape in keratoconus? Well, a number of studies have come out over the recent number of years that have shown abnormalities of scleral shape. And utilizing our profilometry of the sclera, we're seeing these abnormalities. And this study looked at results from the ESP, or the Eaglet Eye Surface Profiler, in some keratoconic and normal eyes, and realized that as the condition of keratoconus becomes more severe and more moderate and advanced disease, the asymmetry and irregularity of scleral profile increases as well. And another study looked at a correlation of the corneal shape and where the steep zones were with the scleral shape, and there seems to be a correlation. So perhaps keratoconus is not actually limited just to the corneal tissue, but likely extends out even out into the sclera. Here's another interesting misunderstanding that we see quite commonly on a lot of conversations, even from the podium that I've seen, and that is the thought that when you do topography on a cornea and you see that classic kissing dove or crab claw pattern as you're seeing now, that's pellucid marginal degeneration. And I can tell you from doing corneal tomography on tons of these patients over the years, the vast majority are actually just variants of keratoconus. So you can take a look here and realize that you don't have inferior thinning, you have the thin point that's actually more consistent with the location of the elevation anomalies of classic keratoconus. So if you just look at anterior elevation and posterior elevation, you would just say that's keratoconus. But what threw you off is looking at that kissing dove or crab claw pattern. And in fact, Mike Bellin published an article really describing this beautifully a number of years ago and talking about what's true PMD. True PMD is a very rare condition. And this is associated with a linear band of thinning, typically inferior, located about 1 to 2 millimeters in from the inferior limbus. So how do we know that? We look carefully at slit lamp, and you could see that band of thinning as evidenced by this photograph. And even on tomography, when you compare the vertical meridian to the horizontal, you can see that localized peripheral band of corneal thinning. And really where it shows is we can expand out the measurement area, as in this particular case, covering about 12 millimeters of the cornea in global thickness. And you see that inferior thinning zone, so classic of true PMD. But the vast majority of patients with that kissing dove pattern, those are really just traditional keratoconus patients. Here's another image of a true PMD with that expanded pachymetric map, where we can see that inferior thinning, and even on the Scheinflug vertical cut image, you can see that localized thinning of true PMD. Misunderstanding number 9, the purpose, expectations, and indications for corneal cross-linking. This is very, very important, that we must be clear with our patients as we counsel them towards performance of indicated corneal cross-linking, what its purpose is, what we can expect, and when it's indicated. We know that corneal cross-linking, its indication is to control progression. We would love to halt progression or at least significantly slow down progression with the use of corneal cross-linking. And we know that the efficacy of corneal cross-linking is quite high. In fact, most studies will show efficacy of controlling progression over 95% of cases. And that the true FDA current indication for corneal cross-linking, as I alluded to earlier in the talk, is for progressive keratoconus, as well as for iatrogenic ectasia from corneal refractive surgery. But as it relates to naturally occurring keratoconus, it's for quote-unquote progressive keratoconus. That being said, and keeping in mind the prevalence of keratoconus, the fact that young people under the age of 20 for sure, and even into the 20s, are far more likely to progress than not progress. Well, perhaps a clinical indication for cross-linking should also include performance of cross-linking for those patients at high risk of progression without necessarily documenting. That would be an off-label use of corneal cross-linking, and maybe and perhaps at some point in the future will become an on-label and approved indication for cross-linking. It is not at this time, but surely most of us who would see, for example, a 16-year-old or an 18-year-old and diagnosing keratoconus, I am not going to wait to document progression before I would suggest performance of corneal cross-linking. I just don't think that that is kind of the moral thing to do, so to speak, especially as we're starting to develop cross-linking technologies that hopefully soon will be even FDA approved and perhaps even covered by insurance, which are epithelium-on versions, which have a lower overall risk profile compared to current FDA-approved corneal cross-linking, although those risk profiles also are actually quite low. So it's something to think about, and as you saw in the paper that I referred to earlier, when you see that 90%, close to 90% of those young individuals were found to progress, well, we don't want to wait for progressive vision loss if we can avoid it. Let's talk a little bit more about corneal cross-linking. First of all, what is it? How does it work? I think it was best stated by my dear friend Andy Morgenstern, who is also a co-executive board member with us on IKA. And Andy said that cross-linking involves the application of liquid riboflavin vitamin B2 to the cornea and saturating it, and then exposing it to a specific wavelength of ultraviolet light, typically about 365 nanometers, that the treatment strengthens and stiffens the corneal structure and can slow and halt progression of keratoconus. It's theorized that the existing collagen is in essence strengthened by cross-linking. Now we know that current FDA-approved cross-linking is only one procedure, and that is the former Avedro, now Glaukos. Now recent terminology for this procedure is the iLink procedure. And the iLink procedure is the only FDA-approved cross-linking procedure here in the United States, and it uses their proprietary Photrexa viscous and Photrexa solutions of riboflavin, along with their KXL ultraviolet light system. And this is an epithelium off technique based upon some of the original work from the Dresden group, utilizing 30 minutes of riboflavin application followed by 30 minutes of exposure to 365 UV using their KXL system. And interestingly enough, I think that terminology is very important. I hear a lot of patients, I even hear a lot of optometrists and many ophthalmologists using the term surgery when we refer to cross-linking. I think that's a misnomer. Even Avedro in their earlier materials that they shared on their procedure used the term a medical procedure, not a surgical procedure. So I always correct our patients when they say, well, when am I going to have my cross-linking surgery? And I'm very emphatic in saying, you're going to have your procedure. It is not a surgical procedure. It's a medical procedure at this date or that date. And maybe it's kind of a little picky, but I think it's very important to use the proper terminology. Now, another thing to think about is we realize that in cross-linking that we typically will and often will get changes to corneal shape and curvature, typically in flattening. But although current cross-linking often results in this flattening, and occasionally it does result in improvements in potentially best corrected and uncorrected vision, these changes are not really predictable at this point in time with current technology. And very often the changes truly aren't that significant in terms of their impact on clinical performance. Because of this also, though, patients should be advised when they're having cross-linking that they might expect some changes to their glasses prescription over time until it stabilizes, and certain types of contacts may need to be modified, especially corneal gas permeable lenses that work on more alignment of the eyes. Now, vaulting lenses I don't find to be dramatically influenced by changes to the shape because elevation changes aren't that dramatic after cross-linking. So I have often found patients that we want to have cross-linking done, but they really want their vision improved, and there may be some time before their cross-linking is done for whatever reason, maybe getting insurance approval or even just scheduling reasons. I fit them in scleral lenses, and I find that it is very rare, at least in my hands, that I have to change those scleral lenses after the procedure. So although I do ask our laboratories to potentially extend their warranty period just in case we do need to make changes, and they've been really good, the labs we've worked with, in understanding that we're going to have patients having cross-linking, but we want to try to improve their vision as quickly as possible and try to keep them out of their lenses for as short a period of time that is possible. And again, vaulting lenses that don't touch the cornea, I find I can get back into lenses even with epi-off cross-linking much sooner. So our last of our misunderstandings for tonight is misunderstanding number 10. And that is, we must not work in silos when we're talking about the management of keratoconus. And I see, unfortunately, many of us in the eye care field, both optometry and ophthalmology, often do work in silos. That we have to approach this disease in a comprehensive management way. We want to improve vision, but we also have to address the progressive nature of this disease and manage the disease itself. So whenever I do an initial consult for a keratoconus patient, I go over that and I said, there's two areas that we need to address. We definitely need to get you to see better if it's already impacted your vision in a negative way, but we also want to make sure, if at all possible, that this disease does not get worse, because ultimately we would like to avoid having to do any major interventional surgical procedures such as penetrating keratoplasty. And we do that today through the application at appropriate situations and times with cross-linking of the cornea. So we know that both of these are critically important. And unfortunately, I've seen patients come into the office that, depending upon the former practitioners they saw, I've seen patients come in where they've been talked to about cross-linking, but nothing about the various contact lens options and vision correction options that are out there. I've seen others come in who have been fit multiple times with contact lenses, and nobody has ever mentioned cross-linking to them. And for sure, based on history, these patients have progressed over time. So it's important that all of us approach keratoconus in a comprehensive management way, approaching vision improvement and control of disease progression. So let's talk about intervention in keratoconus in a very kind of broad way. So what is the purpose of contacts? We know that contact lenses, their purpose to improve vision. It has no impact on progression of disease or halting progression of disease, although back in the day, some people thought that fitting flat lenses really stopped keratoconus from getting worse, and we know that that's not true. Cross-linking, today's cross-linking, its purpose is to stop progression of disease. That is the reason why cross-linking is done. Corneal ring segments or intacts, if they're used, the purpose is to reduce disease severity, potentially improve uncorrected and best corrected acuity, and improve the reception of contact lenses to eyes that have become less contact lens tolerant. The same thing can be said for topo-guided PRK. Purpose to reduction of disease severity, hopefully improve uncorrected and best corrected acuity, and very often these patients still need to wear contact lenses, improve contact lens response. And then keratoplasty, we know the purpose is to provide a clearer cornea for those that have scarred, improved contact lens response, and hopefully some improvement in best corrected visual acuity. This is primarily for patients who have become relatively contact lens intolerant, either due to corneal scarring and/or dramatic corneal shape changes. But in our mind, if we can detect this disease earlier on, intervene earlier on, the number of patients that are going to need keratoplasty will continue to decrease. And we're already seeing that worldwide as cross-linking is having its effect on lowering the percentage of patients, the number of patients needing keratoplasty for keratoconus. So there truly has been a paradigm shift in keratoconus management. And we now know that we can stop progression of the disease, and with that we can preserve vision. So early detection becomes that much more important. And that's the mantra that I want to leave with you today, and surely the mantra of our organization at IKA, the International Keratoconus Academy. And with that, I want to thank you very significantly for your attention over the last hour, and again welcome you to join us at IKA by going to our website and becoming part of the conversation. And for the entire executive board and all of our medical advisors, we thank you for your attention and welcome you this evening. Thank you so much. And our next talk.
Go ahead.
Yeah, I'll leave it to you, bud.
I said thank you so much. Great presentation. We do have some questions, if you don't mind sticking around for just a moment here. First one, what are your thoughts on the topical treatment by Ivina that's used to help slow or stabilize the progression of keratoconus?
I think it's amazingly exciting. We at IKA have been actually approached about possibly getting involved in some of the trials. I mean, I have no experience. I'm just really excited to see any new way, and the less invasive, the better, to halt the progression. Whatever that mechanism might be, whether it's cross-linking or some of these other new technologies, it still depends upon us diagnosing or detecting this disease as early as possible.
And this one asks, up to what age do you recommend cross-linking? I guess, is there an age limit, either young or old, where you wouldn't consider cross-linking, or is it purely based on progression?
Well, okay, obviously there are indications, FDA indications for age. On the young side, we know that, but let's more importantly talk about the older side. This is my approach, and this is, again, this isn't the rule, this is just the Iden approach. So if I see somebody who's under the age of 30, I'm assuming that they are going to progress, and those patients under the age of 30 that I've diagnosed keratoconus, whether they've impacted vision or not, I would suggest cross-linking for those individuals. Between 30 and the early 40s, I generally tell those patients it's a 50-50 deal. You may progress, you may not progress. For those individuals, I suggest very careful monitoring. We monitor them with corneal shine fluke tomography, with anterior segment epithelial thickness measurements, and hopefully very soon with corneal biomechanics, as sensitive techniques as we can possibly find. And if we detect any sort of progression in those patients, we will move forward with cross-linking. Once you get over the age of 45, I generally tell our patients the odds are starting to become in your favor. We still monitor them, maybe instead of every 3 months that we might be monitoring some of our more at-risk patients, perhaps in their 30s, maybe we'll go to every 6 months, and if after a year or two, no progression, we might just do it annually. Over the age of 50, I tell people, I'm going to see you every year, but the chances are pretty darn small that you're going to progress at that point in time. Now, that being said, even for our very young patients that I would want to do cross-linking, let's say under the age of 30, some of them, for whatever reason, whether it's economics or whether it's just concern of procedure, whatever it might be, they may choose not to take my recommendation and want us to monitor them very, very carefully. And I've had that even with young individuals where parents said, I'm not so comfortable with an intervention like that. Let's be sure that they're getting worse. Of course, I respect that. And those individuals, surely every quarter we're running those tests on those patients.
Any experience with oral or topical riboflavin used to promote natural corneal cross-linking?
No.
And let's see, it's easy enough.
Yeah, that's a no.
Trying to see anything you didn't actually cover already in the lecture.
Can I make one quick statement about that?
Sure.
There are going to be all these alternatives, right? All these new and alternative ways. I surely want evidence-based behind them. We have enough patients that we need to treat with FDA-approved technologies that are not being treated because of one reason or another, maybe not being educated properly or diagnosed properly. I love the idea of looking at new technologies, hopefully less invasive and highly efficacious. But with what the tools that we have in our toolbox already, right now, we need to just do a better job.
And then I wonder with this one, is there any certain criteria used to validate progression as far as a certain movement in topography and pachymetry and anything like that? Is it case by case?
So, well, of course it's case by case, but there are various criteria. Now, the FDA in their cross-linking studies looked at changes in Kmax, looked in changes in SimK values, looked at changes in refraction. You can all look up the specifics on those. I don't have slides to share with you, but I could have. But there are also software programs. For example, in Penacam, in Shine Fluke tomography, there is a progression software called a Bellin progression software, which can be used. And I most often will be looking at anterior curvature, anterior elevation, posterior elevation, and corneal thickness in difference maps. And we all know how to use in our topographers or tomographers displays of difference maps. So we look at, today's map on anterior elevation and do a subtraction map from a former map. And that's really, and I'm looking for all the ducks to line up. If just one seems to show progression, well, it makes a little light bulb go up in my head, but I'm not necessarily going to move forward treatment-wise. But if we have a number of those values that are showing definitive progression, that's making me feel more positive about the existence of progression. Now, please keep in mind something very important: the influence of contact lens on corneal curvature and shape. So what we do in our patients that we want to monitor for progression, we want to make sure that the contact lens, whatever it is not influencing our results. So we will ask them to come in and at least not have a contact lens on the eye for that last day. Now, that's very difficult for some of the patients who can't see without their contact lens. And very often what we'll do with that is we'll ask them to do one eye at a time. And I know it's arduous, I know it's challenging, but when we're really concerned about detecting progression, you have to rule out the influence of the contact lens on these findings.
Thank you so much. So part 2 of this presentation with Dr. Gloria Chu will be coming up on Wednesday, May 5th, where she'll pick up a more contact lens approach to this presentation here. Again, thank you to the Scleral Lens Society for putting this on. We'll see you all next time. Stay safe, and thank you again to our presenter, Dr. Eiden.
Thank you and good night.